So, good evening, all. At the outset, I would like to thank Avtar for giving me this opportunity to talk about CRRT and extracorporeal therapy in poisoning. We are all aware of the poisons, and I'll be carrying out my talk in three sections. I'll first deal with the principles of extracorporeal therapy, then I'll discuss some case scenarios, and then special therapies. We are all quite aware of the poisons we encounter: the CNS medications, the sedatives, hypnotics, antidepressants, anticonvulsants, alcohols, the cleaning substances, what we find in household, pesticides, insecticides, and herbicides. And we are well familiar with paraquat, which is very common in our country. Apart from that, we have some unique poisons as well. And we are all well familiar with the broad principles of management of poisoning. We are aware of gut decontamination, where we do lavage, which is generally avoided in corrosive poisons, but generally is done if the patient comes to us within 1 hour. Activated charcoal therapy is done for most of the poisons. Emetics, purgatives are given. This is about the gut cleaning. That's not the focus of my talk today. The second important step is the forced alkaline diuresis. And mostly it's done if the poison gets removed with this therapy. Remember, it's never done for patients with renal failure or those with pulmonary edema. And the next step is antidotes whenever they are available. The last and the most important for us today is the extracorporeal therapy for treatment of poisons. And that would be the focus of my talk. Antidotes, as I said, are available. For example, paracetamol, we all know N-acetylcysteine is available. We have digoxin antibody for digoxin. I'm not going to go through the whole list. You are all aware of this. Now coming to the extracorporeal therapy. So when should we use extracorporeal therapy? Remember, we should use it only if it is required. For example, if the poison has poor endogenous clearance, it's not cleared by the body metabolism on its own, then we can use this. If the normal drug excretory function is impaired, either because of renal failure or cardiac failure or hepatic failure, body is not able to remove the drug. In case there is no antidote, this is another indication for using ECT. And in cases where you have done a gastric lavage, you have given activated charcoal, diuresis, everything, it's not working. The patient is progressively deteriorating despite your care. In those cases, ECT is again indicated. And as I said, despite all supportive therapy, if the drug levels, the poison levels in the body are increasing, this is another indication for extracorporeal therapy. So we use ECT when everything else is not working. And another important thing is which poisons can be removed by this extracorporeal therapy. The poisons which are there in the intravascular compartment are the ones which can be removed easily. The poisons which stay inside the vessels are those poisons which are hydrophilic, which have a low volume of distribution. They don't get distributed to the tissues. And those which have a low molecular weight and can easily be removed by dialysis. Another important thing is those poisons which are strongly protein bound, they cannot be removed by extracorporeal therapies most of the times. The protein binding should not be very tight. So we have discussed which poisons which can be removed by extracorporeal therapy. What are the types of extracorporeal therapies? The most important ones are hemodialysis and continuous renal replacement therapy. There are other ones as well: hemoperfusion, albumin dialysis, peritoneal dialysis, therapeutic plasma exchange transfusion, but they are less commonly used. So I'll be initially focusing on hemodialysis and CRRT. So when do we choose hemodialysis? When do we go for CRRT? Remember, initially, hemodialysis was used for smaller molecules, really small molecules, 500 Dalton. But with the advent of newer membranes, high flux dialysis, we can remove molecular weight up to 10,000 Dalton, and high cutoff dialyzers up to 45,000 Dalton. So molecular weight may not be a criteria as present day time is concerned. It's almost equal to CRRT, where you can remove up to 40,000 Daltons. We used to feel that the hemodialysis clearance will be lower than CRRT. No, hemodialysis is a less costly therapy and gives better clearances, 250 to 400 ml per minute for the poisons. And look at CRRT, it's just 50 to 80% of what we give by hemodialysis, just 50 ml per minute. So hemodialysis is much more effective for fast removal, whereas CRRT can remove slowly. But the advantage of CRRT is in mainly two conditions. If the patient is not fit for hemodialysis because the blood pressure is low, patient is hemodynamically unstable, and another important condition is where we want to prevent rebound from the tissue. Some poisons can get removed from the circulation, but there may be a rebound from the tissue and the levels again go up. And these are the conditions where either you do a prolonged hemodialysis or you can take for CRRT. Now in CRRT, whether you should go for hemofiltration or hemodiafiltration, very easy. Hemofiltration when there is no renal failure, and hemodiafiltration if you have associated metabolic disturbances, acidosis, renal failure, etc. So we have understood, ladies and gentlemen, the broad principles of therapeutic extracorporeal removal. That is, first try out the other things, the lavage, activated charcoal, alkaline diuresis whenever indicated. Then think whether the poison is amenable to removal by these therapies, and then choose these therapies. Out of that, choose hemodialysis if possible. If not possible, you can go for CRRT. We are all well familiar with the CRRT machine. Now coming to the case management, some interesting case scenarios. We had a 38-year-old gentleman with phenobarbital overdose, bipolar disorder. In the medical history, he took 189 tablets of phenobarbital. He was brought in unconscious state, GCS 3 with respiratory distress, blood pressure was 160. So he was intubated and ventilated. His renal parameters, liver functions, ABG, CBP in the initial time was normal. Coagulation screen was also normal. So basically, he was hypotensive, was unconscious, and he was intubated. He underwent lavage, activated charcoal therapy, alkaline diuresis, and was on supportive therapy with IV fluids. The phenobarbital level report came as 221.8 milligram per liter, which is quite high. Should we perform ECT for him? Yes, let us look at phenobarbital. Is the poison dialysable? Yes, it's dialysable. It's a small molecule. It's 50% protein bound, and it is not completely metabolized by the body. So it can be subjected to extracorporeal therapy. Next question is which one, whether hemodialysis or CRRT. Which one do you select? In this case, you would go for CRRT. Why so? Because the patient was in hypotension, where hemodialysis is not a good option. So CVVH was started with 200 ml per minute and a dialysate flow of 2000 ml per hour. And we did not need dialysis for him because renal parameters were normal and there were no metabolic disturbances. So hemofiltration was enough. After 72 hours, his repeat levels were 38. The effluent showed 25 milligram per liter. GCS improved. Even after stopping the therapy, the levels continued dropping, as you can see. So there was progressive improvement and he was extubated. So this patient was successfully managed with hemofiltration. Hemodialysis could have been done for phenobarbital poisoning if the blood pressure was okay. So this was successful management of first case with CVVH. Now case number 2, 19-year-old female came with injection of aspirin, massive dose. And here, in addition to seizures and encephalopathy, she had AKI and pulmonary edema. Blood pressure was fine, but as you can see, severe renal failure, bicarb was 11 and pH was 7.2. Salicylate level was again high, 99 milligram per DL. Lavage, yes. What about activated charcoal? Yes. What about urine alkalization? Remember, I said it's not done if the patient is in renal failure or has pulmonary edema, and hence this was not done. What about extracorporeal therapy? What about aspirin? It's a small molecule, again in the intravascular compartment, only 50% protein bound, dialysable. So we can do extracorporeal therapy. Dialysis or CRRT hemofiltration, what would you want? Dialysis, because she had renal failure and also had metabolic acidosis. Fine, we started her on hemodialysis. 4 hours of hemodialysis were done. Her aspirin level fell down. We were very happy, 37 milligram per DL, but again increased to 64 milligram per DL at 4 hours. What next? What does it show? There was rebound of aspirin from the tissue into the blood. So what do we do now? We initiated her on CVVHDF. Here we went for hemodiafiltration because she needed dialysis And also, she needed hemofiltration because there was a tissue rebound and the level increased after hemodialysis. So after initiation of hemodiafiltration, level fell, she improved, serum creatinine decline. So in this case, hemodiafiltration was useful to prevent rebound. The question may be, couldn't we have prolonged the hemodialysis? We can. We can do repeated hemodialysis as well if we want, or the other option could be a slower therapy, continuous therapy of hemodiafiltration. So this patient also improved. The third lady, 60 years old, diabetic, on metformin. She was fine 3 days before admission, had diarrhea, vomiting, and came with a very poor GCS. She was an altered sensorium. Blood pressure was 71/56, saturations were low, and she had a low score on Glasgow Coma scale. So 3 days she deteriorated like that. And her parameters were, the creatinine was 10, pH was again low, lactate was 18. Ultrasound showed a normal kidney size. So the initial diagnosis was a dumb diagnosis, looks like sepsis. But remember, ladies and gentlemen, always rule out metformin-induced lactic acidosis in such cases who present with a picture like sepsis with gastrointestinal symptoms. It's a strong mimic of that. It's uncommon, I do agree, but it has a high mortality and you can prevent it if you pick it up. And how do you pick it up? We could pick it up because a metformin level was ordered. And what was the metformin level? It was 77. Normal is around 2 milligram per liter. So this is the only way to rule this out in case looking like sepsis with high lactate metabolic acidosis. So again, she underwent the supportive therapy, routine supportive therapy, vasopressors. She was intubated as well. What about extracorporeal therapy for metformin? Can that be removed? Yes, it is easily dialysable, small molecular weight, less protein bound. Volume of distribution is fairly okay. But again, this also has a rebound phenomena. So what does that mean? Hemodialysis alone may not be sufficient. Either you have to do a prolonged hemodialysis or do a CRRT. This lady underwent hemodiafiltration because she also had renal failure and again recovered and was discharged successfully. So this case highlights the importance of picking up metformin-induced lactic acidosis. Though rare, extremely important to pick it up. Now I have discussed about the hemodialysis and the CRRT. Now let us look at some special extracorporeal therapies. Another case, 39 years old male, came with consumption of 30 ml of paraquat. He was otherwise okay, but respiratory distress. The urine diethionide test was positive, blue color, showed severe paraquat poisoning. Renal functions were normal. Coagulopathy was there. So which type of extracorporeal therapy? Remember, this is one condition where hemoperfusion scores over hemodialysis or CRRT. So hemoperfusion. And remember, it should be started early. And another important point is you should start even if the patient is asymptomatic. Don't wait for the patient to develop symptoms. If there is a clear-cut history and urine test is positive, please start. Otherwise, paraquat has a high morbidity and mortality. So this patient underwent 2.5 hours of hemoperfusion per day and subsequently recovered. Always, we don't have such good outcomes with paraquat. Early pickup is important. And hemoperfusion circuit is much like your dialysis circuit. Only thing, instead of the dialysis cartridge, we have the hemoperfusion cartridge. The advantages of charcoal hemoperfusion or resin hemoperfusion is that it removes strong protein-bound drugs very effectively. So apart from this paraquat, you can remove theophylline, carbamazepine, and phenytoin also. In case the patient also has renal failure, hemoperfusion does not support renal failure. You have to do hemodialysis and hemoperfusion both alternately. Side effects are thrombocytopenia, but it is a useful therapy for paraquat poisoning, which is quite common. So ladies and gentlemen, most of the poisons can be removed by hemoperfusion, but it's not required unless the poison is very strongly protein bound. So if the poison is well removed by hemodialysis and hemoperfusion, always go for hemodialysis. And this is just a list of drugs which are better removed by hemoperfusion on the right side. I'm not saying they are not removed by hemodialysis. They can be removed by hemodialysis, but paraquat, it's better to start with hemoperfusion. Now suppose the drug is very much protein bound, around 95% protein bound. Hemoperfusion won't help much. What's the solution then? go for albumin dialysis. Albumin dialysis removes drugs which are more than 95% albumin bound. Even big size drugs can be removed with it. Diltiazem, phenytoin, theophylline are again such examples. They can be removed by hemodialysis, but albumin dialysis is much more effective. Again, you have three varieties of albumin dialysis: single pass, where we use fresh albumin every time, very costly. Then Mars, we have all heard of Mars. Here we use albumin, exogenous albumin, but it is regenerated again and again, so less costly. And the latest version is Prometheus, where we do not use exogenous albumin. We use patient's own albumin. So this brings down the cost further. So just remember albumin dialysis for strongly protein-bound drugs. The next is therapeutic plasma exchange. When do we go for this and when do we go for albumin dialysis? This is also used for strongly protein-bound drugs, more than 95% protein-bound. Some other examples, cisplatin, levothyroxine, for this drugs, therapeutic plasma exchange has been used. And even very big size drugs, 10 lakh Dalton drugs, therapeutic plasma exchange is an option. So rituximab is an example of such a drug. So albumin dialysis may be very costly, may not be available to all of us, but therapeutic plasma exchange can be done in most of our centers. And remember, it's a very good therapy for big drugs and highly protein-bound drugs. The clearance is around 50 ml. So most of the clearance is 50 ml. Whereas with hemodialysis, it's around 250 to 400 ml per minute. So we should remember that. Nothing is available, resource limited setting, go for peritoneal dialysis. Clearance is just 16 ml, very low. Rarely it's done for theophylline if other modalities are not available, but results are not that great. In very small children, exchange transfusion. Drug toxicity in newborns, clearance again very low, 10 ml per minute. So I have discussed a lot of extracorporeal therapies. Which one to choose is important for us. Most effective is hemodialysis. As you can see on the right side, the clearance is 250 ml per minute with hemodialysis. With CRRT, it's around 50 ml per minute. With therapeutic plasma exchange, 50 ml per minute. What about the other ones? Very little, 10 to 15 ml per minute. So remember this figure when you are choosing. Go mostly for hemodialysis unless it's not possible. And this is a summary slide which shows that once you get a patient with poisoning, first see whether gastric lavage is possible, whether activated charcoal is possible, whether antidote can be given. If nothing works, then you go for extracorporeal therapy, otherwise no. And once you decide on extracorporeal therapy, you realize that the poison can be removed by ECTR. Look at the protein binding. If protein binding is less than 80%, check the molecular weight. If molecular weight is less than 10,000 Daltons, hemodialysis. If between 10 to 50,000 Daltons, hemofiltration or high cutoff dialysis, CRRT. If more than 50,000, go for therapeutic plasma exchange. Nowadays, as I said, hemodialysis with high cutoff generally fits the bill. In case the poison is highly protein bound, between 80 to 95%, the therapy of choices, I told you, hemoperfusion. And in case the protein binding is much more, 95%, then think of therapeutic plasma exchange or albumin dialysis, whatever is available with you. So this is a small summary slide which sums up what I have just told. So this is the data from our hospital, which is a 5,000 bedded hospital. We had 153 poisonings in last 10 years. Barbiturates were the most common poisons, followed by supervasmol, 56 cases of supervasmol. This we published our data on supervasmol. Extracorporeal therapy unfortunately doesn't work well for supervasmol, though hemoperfusion and hemodialysis both have been tried. It's not very dialysable. Most of our patients ended up on hemodialysis, not because we wanted to remove the poison, but all of them presented with renal failure, and that's why they were in our unit, and they developed renal failure because of rhabdomyolysis. So this is a very common poison for which ECT doesn't work that well. So we have lots of poisons. I have discussed the broad principles, and I have shown 3 cases where we went step by step, and in some of them went for hemodialysis, in others we went for CRRT. In case, because the poisons list is so exhaustive, you have a doubt, what should you do? Even in the middle of the night, you can call up this toll-free number. AIMS Safdarjung Enclave, Delhi, which has a nation's poisons information cell, 24 hours a day, 7 days a week, 365 days a year. And the content of my talk is based on these guidelines, which are extracorporeal therapy recommendations in poisoning. It's a very good document. So you can all go through that if you want to check out for specific poisons. So thank you, ladies and gentlemen, for a patient hearing. And that concludes my talk.